evening, everyone. I am Dr. Shikha Verma, Medical Advisor for Lupin Oncology. Lupin is an innovation-led transnational pharmaceutical company and is one among top 5 Indian pharma companies. And we pride in belonging to an industry which makes a difference in lives of people. On behalf of Lupin, I welcome you all for today's live webinar on Update on CML, a review meeting of important articles. On this occasion, we have with us Dr. Mb Agarwal sir, who would be moderating the session. Sir is one of the most senior and well-renowned hematologists in the country. It's in fact a great privilege to have you here, sir. Although Sir himself needs no introduction, it's my pleasure to speak a few words about you, sir. Sir is Professor and Head Department of Hematology at Bombay Hospital Institute of Medical Sciences, Mumbai. Sir is also Director of Hematology Center, Mumbai. He is also a consultant hematologist at number of hospitals in Mumbai, including Leelavati and Breach Candy Hospital. Sir holds a number of professional and academic achievements apart from receiving many awards. He is eminent international speaker and conducted multiple workshops at various prestigious institutions. Sir is a president, Mumbai Hematology Group, and a past president, Indian Society of Hematology and Transfusion Medicine. Sir has authored multiple books and was an editor of Indian Journal of Hematology and many newsletters. We welcome you, sir. Kindly take over the proceedings.
Thank you, Dr. Shikha. I'll just share my screen. Can you see my screen?
Yes, sir. Yes.
Okay. So, good evening to everyone. This is an update on chronic myeloid leukemia. It's a review meeting of important articles published and presented during 2020. This webinar is brought to you by Mumbai Hematology Group. It is supported by Lupin Oncology and managed by Mice Ideas. I thank Mr. Visrat Misra and his team from Lupin Oncology, Mr. Rajesh Sharma, Mr. Kalpesh and their team from Mice Ideas, the Executive Committee of Mumbai Hematology Group, faculty of today's live webinar, and all of you for sparing your Thursday evening. Do remember to ask questions, and our faculty will be most pleased to answer them. This webinar is in two parts. To chair the first part, we have the eminent personality of Dr. Hemant Malhotra. It's my proud privilege to introduce him to you. He's Director, Oncology Services, Professor and Head Department of Medical Oncology at Shriram Cancer Center, Mahatma Gandhi Medical College Hospital, Jaipur. Part 2 will be chaired by Dr. Sadashivdu Gundeti. He is Additional Professor and HOD, Department of Medical Oncology at Nizam Institute of Medical Sciences, Hyderabad. We have three presentations during each of these sessions. The speakers and the subjects will be formally introduced to you by the chairperson. But just to name the people, in the first group, we have three eminent personalities, the faculty, Dr. Tufan Dolai, Dr. Chandrakala, and Dr. Kishore Kumar. During the second session, we have Dr. Puneet Jain, Dr. K.S. Natraj, and Dr. Soumya Bhattacharya. Well, thank you so much to give this opportunity to me to speak to you. Now I invite Dr. Hemant Malhotra to take over.
Thank you, Dr. Agarwal. It's always a pleasure and a privilege to be part of the academic activities organized by you. And I think this is a really good idea to recap for our consultants and our residents in hematology and medical oncology the important publications and presentations in the whole year. And I'm really happy that three really beautiful articles have been chosen for the first session, which I have the privilege to chair. And to set the ball rolling, our first speaker, the opening batsman, so to say, is Dr. Tufan Dolai from Calcutta, well-known hematologist from Calcutta. And he's going to review a very nice article on managing CML with comorbidities. So, Tufan, if you're ready, please share your screen and go ahead.
Thank you, sir, and good evening to everybody. And in the outset, thanks to Professor Mb Agarwal and the Mumbai Hematology Group for giving the opportunity. So I will be speaking on the managing the CML with the comorbidity. I am audible, Agarwal sir?
Yes, sir.
Yes, yes. My slide is also visible.
Yes, Tufan, we can hear you and see you. Please go ahead. You're loud and clear. Thank you.
Thank you, sir. So I'll be speaking on the managing the CML with the comorbidity. Basically, the reviewing the few papers have been recently published in this context of the CML with the comorbidity. We know if you consider the CML in the West, it is the disease of elderly. But in India, it is the most common adult leukemia in India. And according to the Indian literature, the published literature, the median age is around 30 to 40 years. So in this age group, I think there is no comorbidity. But yes, I know that India is the capital of the diabetes and also in the heart diseases. If we consider the diabetes per se in India, around to 30 to 39 years, the 11% become diabetic and the 19% become pre-diabetic, and into the 40 to 50 years, it is around the 40%. So if you consider that the Indian population, the majority of the CML lies in this area, so they become high risk for developing the diabetes. Not only the diabetes, the percentage of the first heart attack in the Indian population is also becomes high. In less than 40 years, it is around 25%, and around it is 45% in around the age of around 50 years. So in India, the diabetes and the heart disease, the incidence is very, very high. So managing the patient with the comorbidity in the Indian context is also very important, paramount important. Though we have a lot of the drugs have been developed for the treatment with the CML, recently the imatinib, the dasatinib, nilotinib, and the bosutinib and the ponatinib have been approved for the treatment with the CML. The beautiful portion of that, in this trial, none of the trial they have been incorporated the comorbidity for the treatment with the CML. So in this context, because in their exclusion criteria, they have been usually excluded the organ dysfunction like the liver dysfunction, the renal dysfunction, the ECG poor performance status, both into the IRIS trial and the IRIS trial, and also into the dasatinib, the digestion trial, and also the BELA and the before trial also. So in terms of the comorbidity, none of the trials have been incorporating the comorbidity group of the patient. Still that, by giving these drugs in a non-comorbid person, the chance of developing the toxicity in the form of the ischemic event, the cerebrovascular accident, the cardiovascular accident, the peripheral arterial disease is quite high comparing to the imatinib, particularly the dasatinib into the decision, nilotinib in the NSTND, and the bosutinib in the BELA trial. If we consider the cardiovascular disease, here into the any grade it is around the 4, in imatinib is any grade is around 2%. Similarly, in case of the nilotinib is around 4, and here it is the 1.2. Similarly, in case of the bosutinib also. So even in case of the normal people, they are receiving the TKI, they become developing the cardiovascular cerebrovascular disease. So the TKI is itself a risk factor for developing the cardiovascular disease. Though we are improving the survival, more than 90% by the 10-year survival of the CML patient by giving the different TKI drugs, but what about the comorbid group of the patients? In that group of the patients where there is existing heart disease, there is existing lung disease, and a lot of things in there, what is their importance? The comorbidity status have been reviewed by the German CML group, that is the CML study 4. And in this trial, they are using the Churchill comorbidity index, the different parameters they have been incorporating, starting from the heart disease, starting from the vascular disease, and the liver disease, the diabetes, all these things they become incorporated. And beautifully, if you look at the Kaplan-Meier survival analysis curve in terms of the CCI, means the comorbidity scoring, if it is 2, the 8-year survival of the imatinib with the drugs is around 94%. If you have a 7 comorbid index means score, the chance of survival is 46%. So if we have a comorbidity, then your chance of survival is less. If you consider that without any age, this is also around 48%, vis-a-vis the 90% in terms of the comorbidity scoring system. So the comorbidity is also matter in terms of this overall survival in patient with CML. Not only the comorbidity of the managing the patient with TKI, but a lot of the other things also important in terms of this different drug interruption, the drug side effect, and also the chance of the surviving, the mortality and the morbidity is also become a matter. In terms of this toxicity and the drug reduction, the achievement of the DMR, The TFR is become seriously hampered, and obviously they are unable to achieve the normal life expectancy. So we learned from the trial that the imatinib is becomes long-term toxicity is very good, and there is only the mild edema and cramps and GI. Bosutinib, there is a problem with the GI problem. Nilotinib, we learned that if the patient has diabetes, hyperlipidemia, the cardiovascular disease, the peripheral arterial disease, there is a problem with nilotinib. Dasatinib, similarly, in case of the lung disease, the pulmonary arterial hypertension, they become a problem, which is learned from our important trial. So how do you select the TKI based on this comorbidity? Based on the different trial, if you have a hypertension, you try to avoid the nilotinib, ischemic heart disease, the cerebrovascular disease, the peripheral vascular disease, try to avoid it. If you have a prolonged QT interval and congestive heart failure, try to avoid it. GI problem, you try to avoid this, the bosutinib and subtype the dasatinib. Pulmonary hypertension, we avoid the dasatinib. And the GI problem, you have to avoid the bosutinib. So depending upon the comorbidity, how the drug is becomes different. This is not only for the first line, even into the second line and into the third line also. Because the ponatinib have been approved for the using this patient, ponatinib had a lot of the side effect in terms of the cerebrovascular and the peripheral vascular diseases. So we have to be balanced in terms of the toxicity and in terms of the CML acceleration and the blast crisis progression. So we have to choose the drug based on the different comorbidity. So depending upon the comorbidity, our choice of the drug will be cardiovascular and the history of QT prolongation, the dasatinib. The imatinib will be there. Similarly, the bleeding disorder, we have to choose the imatinib, avoid that to be bosutinib like this. We have to think for that also. So this is the beautifully have been published into this the AS education book that if you have a diabetes, less prefer the nilotinib, the pulmonary disease, less prefer is the dasatinib, GI disease, the bosutinib and the imatinib, cardiovascular nilotinib and the dasatinib, peripheral vascular, avoid the nilotinib, liver disease, avoid the bosutinib, and the renal dysfunction, you try to avoid the bosutinib and the imatinib group of the drugs. Another aspect that if the patient has a problem with TKI, so we have to monitor for the different toxicity profile, different the organ dysfunction for picking the different side effects, particularly the cardiovascular, the pulmonary, and the metabolic abnormality. This becomes beautifully reviewed, this article, the blood review. In terms of the heart failure and the QT prolongations, then you have to be assessed baseline, the CBS assessment, the ECG and the echocardiogram. Then you have to monthly assess, then subsequently 3 to 6 monthly, we have to assess particularly the ECG and echocardiography when it is clinically indicated. In terms of the venous thrombosis and the peripheral vascular disease also, we have to be offering in case of the ankle brachial pressure index and also the blood pressure in the first line and the first visit. Then subsequently the monthly and then 3 to 6 monthly you have to only measure the ankle brachial pressure index. You have to more frequent in terms of the nilotinib and also in case of the ponatinib. In terms of the glucose intolerance and the lipid profile abnormality, you have to be also cautious, particularly in case of the nilotinib and the ponatinib. It is not recommended by the dasatinib and the bosutinib. Then you have to be followed every 3 to 6 months by the glucose and the lipid monitoring for nilotinib and the ponatinib, not into the other drugs. Pulmonary toxicity also similar kind of thing is there. If the patient develop the pulmonary problem, then only we investigate, otherwise we will not investigate. So to conclude that, in terms of the CML disease with the comorbidity, this sometimes becomes evident, and the comorbidity might have a significant adverse effect in the long-term survival of these patients, and the presence of the comorbidity may also affect the risk of developing the adverse effect with the TKI. The coexistence of the comorbidity with the CML, we need to close monitor the patients, not only to the PCR, the monitoring by the BCR ABL, we have to monitor the overall health conditions of the patients. And in terms of this, the holistic approach of the CML with the TKI, the comorbidities becomes very, very important, because even in case of the comorbid individual, we try to achieve the near life expectancy. So in terms of the CML with the comorbidity, the two important aspect is there. Patient has a comorbidity, we have to select the drugs. And the second thing is that patient has a no comorbidity, but they may develop the organ dysfunction that need to pick up early, and ultimately we have to manage optimally to improve the life expectancy of the patient with CML. With this, thank you very much, and I am happy to answer some quick questions and answers. Over to the audience, Manohar sir.
Thank you very much, Dr. Tufan. I think a very, very nice presentation and very, very important presentation, which will help you in choosing your first line TKI for CML and also your second line TKI. So I don't see any questions on the chat box. Maybe I can ask you a question which would be of interest to our listeners, Tufan. What are the long-term toxicities which we would like to monitor when a patient is on imatinib? Because all of us have a large number of patients on the GPAP Gleevec, and we have patients who are 5 years, 10 years. Some patients are also 15 years down the line. What long-term toxicity should be monitored in these patients?
Yes, sir. This is a very, very important question, particularly the imatinib, because they have been approving in the 1990. So already the 20 years already passed. This is on the imatinib. So the recommendation is that the bone mineral density aspect is very, very important. Then come to the hypophosphatemia is another important aspect. The 25 with vitamin D is important aspect. And endocrinology monitoring, particularly the thyroid, you can order. In general, the lipid profile monitoring is not recommended. So if you review the imatinib with this long-term problem, majority of the causes, the musculoskeletal problem is the main problem into the long-term with Gleevec.
Very true. And some long-term renal toxicity is also being discovered. So, if you have a patient on long-term imatinib, it might make sense to do the creatinine once in a while, every 3 months and every 6 months. And particularly if there is a pediatric patient who's on imatinib, then skeletal abnormalities and metabolic abnormalities are again important and common, and calcium and phosphorus intermittently needs to be monitored, right, Tufan?
Right, sir. Right.
Any comments from Dr. Agarwal or Dr. Chandrakala?
Nothing from my side. Thank you.
So great. I think like our opening batsman has done more than justice to our cricket match. Thank you, Dr. Tufan, for a wonderful talk. We'll move on. The second talk is by Dr. Chandrakala, and Dr. Chandrakala, all of you know her. She is a professor and head department of clinical hematology at the GS State Medical College and the KEM Hospital in Mumbai. And Dr. Chandrakala today is going to talk to us about long-term results of dasatinib in the frontline treatment of chronic myeloid leukemia. And all of you are aware that, since the expiry of the patent of dasatinib, we have a plethora of Indian drugs, Indian generic good quality dasatinib available. And we are now, much more confident in using them first line and in second line. And the Dessasian trial, some of us were participants in that trial. Dr. Agarwal and Dr. Sandeep Shah were key investigators in that trial. We have long-term results of that trial available now, and Dr. Chandrakala will take us through those. So Dr. Chandrakala, we can see your screen. You have 15 minutes. Please go ahead. Thank you very much.
Thank you very much, sir. So I thank Agarwal sir and Eamon Malhotra sir for such a kind introduction. So I'm going to talk on the long-term results of dasatinib in the frontline therapy of CML. So I'm going to talk in these headings. What we are concerned about the long-term is whether the whatever the efficacy we are seeing in the initial part is whether sustained response is there or not. Other, how safe is this drug to continue for a lifelong therapy? So in this, I'm going to talk about a little bit of the Dessasian study and long-term data which is recently published by the MD Anderson, and long-term data on the low-dose dasatinib. So Dessasian study was stopped at 5 years. We all know that 5-year data cutoff was published in 2016. So what I want to stress on this is at the end of 5 years, 61% of the patients were on dasatinib, around 39% of the patients discontinued the drug. And the median average dose was 99 milligram, and the 5-year MMR was 76%, and MR 4 point was 42%. This is just as we are taking this as a standard, which we have seen in the randomized control studies. So this will be compared to the other studies, whatever we have in the long-term studies. So you can see the response with the dasatinib. You can see the blue line is every time it's increasing. I'm only talking about the molecular response in this. Every year, the molecular response is becoming better and better over the 5-year period. Even MR 4.5, every year there is a better response. At the end of 5 years, we are seeing MR 4.5 at 42%. So we know the response is much better and response is sustained with this. So, and then patient status at the end of 5 years is only 61% of the patients continued on dasatinib, same as with the imatinib, 63%. And only two things we are concerned about mainly is the treatment failure and the toxicity. Treatment failure was 11% and intolerance to other toxicity was 16%. So approximately about 24% of the patient, 25 to 30% of the patients discontinue the drug either because of the failure or because of the toxicity. That is, we have seen at the end of 5 years in the Toxicity study. The main toxicity, as you have heard just now in the talk, is pleural effusion. It's around 28%. This is the division which we have seen in the Toxicity study. And we have to see in the next follow-up after 5 years whether the pleural effusion is still seen or not. Then we have to see in the next few studies. And other one is pulmonary hypertension, which was seen in about 5% of the patients on dasatinib. So these are the major toxicities which was seen in the Toxicity studies. So Toxicity study showed the dasatinib is better in all the aspects compared to the imatinib except this pleural effusion. So we know this drug is safe at 5 years. So do we have a long-term data? Yes, this is a long-term results which is presented, which is published by MD Anderson. This is 11-year data. And this is the longest data which is available with the dasatinib as of now. It's about 150 patients. It's the phase 2 study. And it was continued for about from 2005 to 2014. Data cut off by about 11 years follow-up. That was this is the study which shows the longest follow-up with dasatinib. I want you to concentrate on this actually. Most of the Western data shows high so-called risk is about only 9% of patients are high so-called risk. And see the WBC count is from 11 to 65. So this is actually the lot of patients what we see in India is usually very high counts and patients are in the high risk. And the bone marrow blast is also 1 to 2%. This is about the MD Anderson study, baseline characteristics of the patients. And yes, very good response. At the end of 1 year, 93% of the patients had cytogenetic response. And at the end of 1 year again, MR4 point was 38%. And at the end of 10 years, MR4.5 was 77%. It's almost like 2/3 of the patients can go into TFR with this drug. And this is the response is sustained. You can see the curve has become very flat with the cytogenetic response. And with the molecular response, the MMR and the MR4.5 and MR4 it's improving every year actually, and MMR it's like stable. There is no loss of response. Actually, usually not that much difference once the patient achieves the MR, but MMR at the MR4.5 is much better at the 10 years. So what is the things we have to think of is dose reductions. We have to take very easy when we are patient the starting on dasatinib. Around 100 patients require the dose reductions because of mainly pleural effusion, fatigue, and the headache. At the end of 11-year follow-up, like dasatinib, 63% of the patients were on dasatinib, and only about 21% of the patients were on 100 milligrams. So when we are giving dasatinib, we have to look for toxicity and reduce the dose as and when required. And the main reason for the discontinuation again is toxicity in about 14% and loss of response in 5%. So toxicity is a major cause and loss of response is very, very less with the second line drugs. So did you had any TFR with this, the long-term data? Yes, there are only about 17 patients. They also had a projected TFR of 58%. Everybody should be surprised when I talked about 77% with the MR 4.5. They have told that these patients were initially counseled that they have to be on indefinite therapy. So that is the reason most of the patients did not go off the therapy. That may be the reason for this low TFR in this study. So toxicity, what we are seeing is again hematological toxicity. We have seen dysphagia, thrombocytopenia, anemia, and leukopenia. Pleural effusion was similar, 26%. I wanted to concentrate on it was initially high in the first year. As the years progress, the percentage of pleural effusions is reducing to 1%. So we are actually pleural effusions are decreasing in the patient as the patient taking the drug. The other pulmonary hypertension was very, very less. And this study is the only which shows that 9% of the patients had atherosclerotic events, like either cerebrovascular events or the cardiac events were seen in this patient, 9% in this study. And other one which I have discussed is about 11% of patients had grade 3 and grade 4 infection. This is the long-term data which is different from the Toxicity study. So this is about the long-term data on the 100 milligram of dasatinib. This is about the low dose dasatinib is 50 milligram. This is from the recently published data. Most of you as have read this article. So just to review this, 83 patients were put on 50 milligram. And again, you can see again 9%, only 7 patients were high risk, high so-called risk in this study. And the response is very beautifully demonstrated. Here, CCYR is very good. At 12 months, 95% patients achieved the CCYR, and even MMR was at 12 months was 81%. So even dasatinib 50 milligram is equally efficacious like 100 milligram, what we have seen in the previous trials. And it is comparison between dasatinib 100 milligram and imatinib. The blue one is the dasatinib 50 milligram. You can see the CCYR is better in all the like 6 months, 9 months, and 12 months milestones. And again, molecular response, MMR, is better when the patient is on 50 milligram compared to dasatinib 100 or the imatinib in this, like at 12 months. See, it's a 12 months data. And we have is again, the EMR is much better. Actually, it's almost equivalent to 100 milligrams. So the point is the better efficacy is same with the less side effects. So in the past, I have shown the drug discontinuation is 11% because of the toxicity. Here, none of the patients discontinued the drug because of the toxicity. The dose reduction was seen in 6 patients, and 77 patients were on the study. Only 5 patients are treatment failure. So when you give a low dose, the toxicity is much less when the patients on this. Only 6% of the patients had pleural effusion on the low dose dasatinib. So I want everybody to see this, because so-called high risk or the intermediate risk in our country, this is published by in India, and the high risk is 40% and 15 ms. So in many studies, it shows about 30% is an actually high risk, so-called risk in our country, and the WBC count is also very high when the patients presents to us. So this is a ASH 2020 book, which shows that second generation TKI is recommended for majority of the patients. It's a very like age more than 80 years, and here along with the comorbidities, whatever the patient we can select, but second generation can be given in a patient with the CMLSA and a de novo patient who is newly diagnosed. To conclude, dasatinib has shown a sustained efficacy profile with a good CC version with 100 milligram and 94%. This are 37 to 40, the patient is on 100 milligram, whereas less than 10 and 50 milligram. Even pleural effusion is 6% when the patient is on 50 milligram. Then I feel both dasatinib so-called high-risk patients was around 9%. So the patients which are so-called high-risk, hence dasatinib we need more data longer for us to start. So this is just a summary of whatever I have gone through the study.
Thank you, Kala. Very summary of. I again don't see any questions on the couple of questions. Have you seen some increase in, like you've been using, all of us have been using dasatinib for several years. Have you noticed increase in infections, increase in unusual infections, and more patients who get dasatinib?
So we have not seen, sir, actually. Our follow-up, we have maybe around 5 years. And recently only we started using more of dasatinib because of the cost. Otherwise, we have not seen any patient who is having the longest which I shown, but otherwise more.
Okay, thank you very much. I have very reactions, and one patient I remember had tuberculosis and not only miliary lymph node immunity. You may have to think about that.
Yeah, I have one comment. Started the everything out of tuberculosis. Should be very cautious, in especially Indian scenario. I think like it recovered now, still they are on the has high so-called.
Yeah. Tough now because we have 100 milligram to the patient. If the patient doesn't, a little more like a mature.
I agree with Dr. Chan. Clearly conveyed from single milligrams, maybe still we have very appropriately pointed out. Most of our patients are high so-called.
Vikram Matthew.
Yeah. So the question
you pointed out, sometimes the imatinib, the 100 grams of this disease and the cerebrovascular disease, in that group of
from day one, you have to have two excellent. We have Kishore Kumar. We can.
Plus, we know how a lot of so for the dinner what I made for myself, I'm not about and it was quite a poster boy for chemotherapy. And the topic that was given to me today, actually, if you look at the history of wisdom, as a personal data, a lot of passion for quite and we have out an easier effect. Most of we are moving as we nowadays just talk about therapy being asked by our patients what our data or I have come forward one step ahead. I'm not curing the cancer. I may try to be remission after some the tolerability and adherence with the generation nilotinib or bosutinib. So at this point in time, So these are certain things I think we should be kind of sometimes over the of dying due to CML are having guidelines and NCCN kind of say, compelling us to do a bone marrow to look in for additionals are available very easy basis when they are done like the P50 doing back generation. Berlin, Ponatinib, ELN doesn't have a CML at diagnosis with an upfront second generation is very ENEST or even the difference in the reflected in the long-term overall survival as well as I think will matter. So yes, these are all the points which will kind of early molecular has been proved in both decision tighter response and thinking about this overall survival data. We have to kind of vaccine for us is going to somebody was on a first 6 months be a more better to kind of the patient with is going to be the applying some comorbidity and TFR what drugs naturally cardiovascular and these things thrown that is one concern in the trial itself. So the
availability of generic. And I think the take home from Dr. Kishore's talk would be that high-risk disease, which includes, and then from one of our Dr. Sada Chandrakala, experts in
No, sir, nothing. No.
myeloid
molecule becomes high. Dr. Chandrakala, we close this first. Pleasure and privilege to be part of this.
To chair the
Opportunity to chair this group publications. That time, if you have the
Yes, sir.
So first of all, a big thank you to MBA sir and the organizers and Lupin for pleasure to give a talk and more than anything else, participate and learn from pleasure. So I have 15 minutes. I'll be view time making on 3 advanced phases of CML. On the right, you could see the one of the slides that it took the limelight for a long period at the end of 10 years. A journey like imatinib, there was which showed that it was introduced. The list at $26,000, 26 a year. That was. But over a period of time since the introduction of generics over, with drug actually rose to almost $120,000 set its wide availability to resourceable. All these brand manufacturers continuing to profit of it through copies and helped thousands and thousands of published. 159 and the complete cytogenetic Nizam's Institute of setup, which is a big cash strat. Median follow-up was almost similar. Those patients who had completed the cytogenetic responses, there was actually no difference in both the groups. In patients achieving complete cytogenetic response, patients achieving a major molecular response, and those patients who had a 4-log reduction in the BCR-ABL transcript. So practically similar response in both the groups. Those patients who had lost to follow-up were also almost similar, 19% in the innovator arm and 22 to 9% in the generic arm. And those patients who had a poor adherence were similar. Number of patients who were transforming into more accelerated phase and blast crisis were also similar. In fact, there was no difference in the EFS, the freedom-full survival. This study showed that there was comparable efficacy and safety of the generic and the innovator versions of imatinib in patients with CML. And as you can see, the patient demographics, the median age was almost similar, almost equal number of males. The presenting counts and the was also similar in the innovator group and the generic group. So overall, the demographics was similar in both the groups. Of course, studies, and these are the Kaplan-Meier curves with no difference in the event-free survival, failure-free survival. Major difference or an inferiority in terms of the side effects among the generic group of imatinib, that was VNAT from Tata Memorial Hospital, and this also showed that there was actually no difference in those patients who were taking the innovator imatinib versus the generic imatinib. Again, most of the studies in the time were based on VNAT and NATCO-based studies. About those patients who have been initially on innovator imatinib and then switched over to generic imatinib. So this was a study from MD Anderson, and this was, I think, published in 2019. And this was again an observational retrospective study wherein patients after 2017 was changed over to generic imatinib, and there were 38 patients like this. They were all had achieved a complete cytogenetic response before the switch. Almost 95% were in major molecular response, and almost 75% were in MMR 4.5. The median duration of generic imatinib was 19.4 months. What was important is none of the patients actually lost the major molecular response after switching over to generic imatinib. Adverse events, they were noted. There was some edema, muscle cramps, nausea, diarrhea, fatigue, but they were well tolerated. So the conclusion was that generic imatinib was well tolerated, and longer follow-up is of course needed. More prospective studies were needed to be able to confirm this, but overall well tolerated. This was one of the prospective studies which had seen, which had looked into the persistence of generic imatinib for CML. This was a matched cohort study, and this was a prospective study. This was from Montreal, Canada, the Jewish General Hospital, wherein two groups were randomized, both 167 patients, the branded imatinib group and the generic imatinib group, almost equal demographics. And here, there was obviously a concern about similarity and bioequivalence for generic and branded imatinib. So what they looked at was persistence and treatment discontinuation because of side effects in these two groups. So this study showed that persistence was actually lower with the generic imatinib, and that happened because of a higher amount of adverse events with the generic imatinib. And if you see in the Kaplan, in this top graph, at 3 years, the rate of persistence with generic imatinib was 72.8%, but branded was 88%, and this was statistically significant. At 3 years, the rate of treatment without discontinuation was almost similar. And those patients who had shifted, there were almost 36 patients from generic imatinib who had switched over from the generic imatinib, and the concerns were mainly toxicity and intolerance. So there were some biases with the study. The biggest and probably the most obvious bias was that those patients who would have shifted over to branded imatinib would have their cost of the drug being reimbursed by the insurance provider. So that was a major reason for sway. And the study had its biases. That was the biggest bias that was there. There were others, of course. The sample size was small, but this was the concern that was shown by this Canadian study. Again, this was an Italian study. 12 institutes from Italy came together. 200 patients were studied, and in fact, what they found 3 time points, molecular PCRs, individual PCRs before and after switching. And in what they realized was the median PCR values after the switch had actually reduced compared to values observed before the switch. There was, in fact, a significant statistical difference between these values in favor of generic imatinib. So those patients with PCR transcript values had actually decreased after the switch was around 52%, stable 24.5%, and some increased in around 23%. So this data indicated that generic imatinib did not have deleterious effect on CML control and presented an acceptable safety profile, though there were some side effects like higher amount of muscle cramps, periorbital edema, diarrhea, which was statistically significant, but they were found to be similar or even better than the innovator imatinib. And these were the side effects that were shown. Again, this is a busy slide, but again, there has been a lot of data which also showed that there were some 445 patients which were analyzed, and 285 on the original innovator drug, and 160 which had shown on the generic imatinib. And this group actually showed that those patients with generic imatinib had a higher rate of failure at 3 months and a lower OS, PFS, and EFS at 24 months. This was again a Chinese study which had shown no difference between the generic version and the branded version of imatinib. In fact, they also shown that there were no side effects which were higher than in the generic imatinib. So there is a lot of data which supports the use of generic imatinib. Some also say that there is a higher risk of side effects. Some say that there is a persistence of higher treatment discontinuation in the first few months. But I would conclude this my talk as saying that based on available retrospective studies, it offers equal efficacy. It has a lower economical burden on an average Indian patient. It can show additional side effects which might lead to a lower rate of persistence, but these are well tolerated, and larger prospective studies are needed to actually really compare generic versus a branded imatinib. Thank you.
Yeah, thank you, Dr. Puneet Jain. I think you wonderfully covered all the topics of all the articles related to generic imatinib. Yeah, thank you once again. I think we presented our data. There is a name Nizam's data by Dr. Madhav. It is a 2016 in ASH. It's an oral presentation from India. I think we are very proud of that one. I think we published the same data in clinical lymphoma, myeloma, leukemia by Contagion. So there's the data. I think what you have presented just now. Thank you once again. Any questions from audience? No, I think there are no questions from any chat box. Any other comment from Mb Agarwal sir, any other expert?
Excellent presentation. That's it.
Yes, thank you. So shall we go to the next one, sir? Yeah. Yeah, the next talk is by Dr. K.S. Nataraj, the senior consultant and hematologist and a consultant bone marrow transplant physician at Narayana Health City, Bangalore. Dr. K.S. Nataraj, and he's going to talk on extramedullary blast crisis of CML. Dr. Nataraj.
Dr. Nataraj, we won't be able to hear you, sir.
Yeah, we can see your presentation. Yeah, we can't hear you. Hello, Dr. Nataraj? I'm unable to hear your voice. Sorry.
Hello.
Yeah, hello.
Am I audible now?
Yeah, now audible. Yes.
Yes,
Please
sir.
go ahead.
Yeah.
So right now, am I audible?
Yes, sir.
Okay. Hi. Good evening, everybody. Is my screen visible?
Yes, sir. It is visible.
Okay. Thank you. So at the outset, first I would like to thank Dr. Mb Agarwal sir and Lupin for giving me an opportunity to discuss what little bit I know about extramedullary blast crisis. I think all of us know that CML is a curative malignancy at this point of time. So we all have to find ways to make sure that this thing doesn't happen, blast crisis doesn't happen in any of the patients with CML. So just to have a definition, what is extramedullary blast crisis is development of an extramedullary disease caused by infiltration of blast, regardless of the proliferation of the blast in the bone marrow, is called as extramedullary disease. It is very, very important to know that though the bone marrow is normal to begin with, just treating extramedullary disease with local radiation or some sort of local therapies or with systemic TKIs is not going to help them to reach outcomes as similar as chronic phase, because usually after a few months there will be a hematological blast crisis. So it is sort of an heralding sign for the upcoming blast crisis in the bone marrow. So it needs to be dealt as similarly as blast crisis in bone marrow. So there is about usually 7 to 17% of patients present in blast phase in India, because it may be lesser in US and other developed countries, but in India we see patients in quite advanced phase every time. And commonest sites are lymph nodes, skin, bone, and central nervous system, and it can happen in both myeloid and lymphoid lineages. And sometimes reticulin fibrosis or collagen fibrosis may only be the major marker of blastic phase. So what is the reason why blast crisis happens in patients with CML? One of the major reasons why blast crisis happens in CML is because of increased activity of BCR-ABL. It is just a direct consequence. So why does it happen? It happens because either there's a chromosomal abnormalities or there are mutations in chromosomes which are involved in genes which are involved in controlling the cancer, like tumor suppressors or promoter genes. So common reason why this kind of blast cases happens is because of additional cytogenetic abnormalities abnormalities, mainly addition of chromosome 8, that is trisomy 8, and an additional PH chromosome, and then sometimes isochromosome 17q and additional 19 chromosome. They're all non-random, and then this is the route majority of the time CML takes to shift from chronic phase to blast crisis. And minor routes there are other things, deletion of Y and other rarer changes, but they may not be mainly involved in pathogenesis. They may be an associated changes. But commonest mutations which are seen in myeloid blast cases are P53 gene related mutations, and in lymphoid blast cases is P16. Though there are other mutations, I think Dr. Kishore pointed out about RUNX1, IKZF, TET2, ASXL1, WT1. There are other host list of mutations which can also get mutated in ALL and AML. The same things can get mutated, and then they can directly present in blast crisis. So why we should treat, what is the rationale for treating blast crisis? Why we should treat is, of course, we have to cure the patient, we need to treat. And what is the rationale for treating blast crisis is to make sure that we hit hard and hit early to reduce the BCR-ABL positive cell pool and as early as possible and as deep as possible. That is a basic dictum of treating BC. The most important thing is convert BC to CP, and then as soon as they reach the CP, immediately take them for transplant. What will happen if you don't take them to transplant, if you directly go ahead with only TKIs? Because the responses are transient. These transient nature of responses to TKI, because there are some cells which are sensitive to TKI, but there are some cells which are developed BCR-ABL independence. So this BCR-ABL independent cells will get repopulated, and then they will form again a blast crisis. This is a host list of mutations. What are the reasons why someone develops like a blast crisis? Is either there is a genomic instability. This is a major place where chromosomal abnormalities such as trisomy 8 and all these things work on. And there's an enhanced proliferation of survival and enhanced self-renewal, or there is inhibition of tumor suppressors, so ultimately leading to block of myeloid differentiation and then leading to myeloid blast cases. So what is the way that we treat? It is very, very important that we test for tyrosine kinase domain mutations, that is imatinib resistance mutation analysis for every patient, even if they are presented directly in blast cases, because sometimes they can harbor those mutations, and then we can choose the drugs based on the mutation reports. And majorly the treatment involves tyrosine kinase inhibitor plus an acute leukemia based strategy. Usually we give TKI plus 3+7 for myeloid blast cases and TKI plus BFM based protocol for lymphoid blast cases in our center. So which TKI we'll choose, whether we'll choose first generation or second generation, I think majority of the times we choose second generation TKI. Whether is it based on strong data? Yes, it is based on data. I will show you the data in coming slides. And always we have to understand that the success of achieving remission in patients with blast cases is quite less when compared to acute leukemia. Though we give considerable intensity treatment by adding TKI and then 3+7 or BFM, outcomes are not as similar as de novo acute leukemias. So if there is an organ function limitation, for example, if there is a blast cases involving the extramedullary blast cases involving the bones of the spine, causing the compression, or if there is a blast cases involving the nodes causing the tracheal compression and breathing difficulty, then of course local radiotherapy is as an emergency measure is indicated. Now coming to which TKI is indicated. If you see, these are the TKIs which are currently available in India, except the ponatinib. Maybe ponatinib also in some way they are accessible for some patients. So if you see, though hematological responses happen in good with imatinib, dasatinib, nilotinib, bosutinib, everything, but cytogenetic responses and then 1 year survivals are better with second generation TKIs, dasatinib or nilotinib. If you see, dasatinib or nilotinib gives about 42 to 50% of 1 year survivals when compared to 22 to 36% in imatinib, whether it is myeloid or lymphoid blast cases. So other thing very, very important to understand is majority of the times if there's a blast crisis involving the central parts like spine or lymph nodes nearby, then they can also harbor blasts in CSF, though we may not be able to see it on CSF analysis at the diagnosis. Based on this, we always prefer dasatinib as a good therapy line in blast crisis patients compared to nilotinib or other drugs. That too, preferably in lymphoid blast cases, we would prefer to give dasatinib over any other second line agent, unless they have got T315 mutation, where ponatinib is the only choice that we have at this point of time. So after achieving remission, when to transplant and how to transplant, As soon as possible, once the chronic phase is achieved, we should transplant the patients with whatever the donor that is feasible, whether it is matched sibling donor or whether it is a matched related donor or a haplodonor. And whether can we give reduced intensity condition? I think outside a trial, we should never use a rig transplant for a CML blastocysts patients, whether it's extramedullary or medullary blastocysts. Even extramedullary blastocysts needs a transplant. We cannot cure extramedullary blastocysts without a transplant. So rig should never be considered outside a clinical trial. And how can we prevent this blastocysts, extramedullary or medullary blastocysts? Most important thing is monitoring for milestones. Because without milestones, if somebody is not achieving milestones in right time, that is a warning sign for all the clinicians and the patients that there is some trouble which is going to happen shortly. So we should monitor properly milestones as per ELN guidelines or whichever that each center follows, whether it's NCCN, ELN, or whatever the guidelines they follow. But if they are not achieving milestones to assess right time mutation analysis and then switching the TKIs, may make the patient better and then may prevent blastocysts in patients. So after knowing a little bit basics about extramedullary blastocysts, I will present about 2 to 3 cases which are patients who presented with extramedullary blastocysts. Here he was a 43-year-old gentleman diagnosed with chronic phase CML, started on imatinib. He was non-compliant. At 8 months, developed 20% blast in the blood. Marrow showed about 4% blast. So that means he gets defined as blastocysts, and he was started on dasatinib. Again, became non-compliant after a few months. Then in coming about 4 to 5 months, he came back to ER with severe abdominal pain, and CT abdomen showed a 4 by 3 centimeter retroperitoneal soft tissue mass. And these tissues of the tissue mass was biopsied, and biopsy showed sheets of atypical and medium-sized blasts. They were positive for CD34 and 117, 333, and GATA3. They were negative for 1A, 2, CD4, even MPO, and then they were negative for 4, 5, 7, 8, and TDT. And flow was done out of those samples from the biopsy, and it was positive for cytoplasmic CD3. And fish showed about 91% of cells positive for BCR-ABL1. And there were no monoclonal or TCR gene rearrangements. So overall, a diagnosis of ETP-ALL blastocysts of CLL was made. Now coming to T lymphoid blastocysts in CML, it is extremely rare and it happens in about 0.01% of all blastic phase. And extramedullary disease is seen in all the patients, and they have very poor survival of 30% even in young and fit. So this patient received treatment with cypercivat plus dasatinib. Patient achieved only PR. He could come back. The complete clearance of the tissue could not be done. But he underwent an allo-SCT, and after allo-SCT, he is doing well and is still alive. And this is a second case in which a 5-year-old male child diagnosed with CML in chronic phase, not compliant to TKI therapy, developed an headache about 8 months after the primary diagnosis. On admission, hemoglobin was 13, WBC was 19,900, platelet was about 2,73,000. Bone marrow was suggestive of CML in chronic phase. MRI brain did not show any abnormality, but CSF showed abnormal cells pleocytosis, and there were also blasts in the CSF, which was positive for lymphoid blastocysts. So patient was treated with myeloid blastocysts, it showed. He was treated with triple IT therapy, TKI, and an induction chemotherapy with daunorubicin and cytarabine. TKI was dasatinib, and followed which he was in remission. He was advised allogeneic transplant, but they were not willing. But he still continues to be in remission at 20 months follow-up with TKI. But this is not the right thing to do. Right thing to do is to convince the patient for allogenic transplant. Now coming to third case, it's about a 17-year-old female patient presented with left hip pain, and MRI revealed an osteolytic tumor of the left greater trochanter. At the same time, CBC was done, though the patient actually reached orthopedician earlier than any physician because of the left hip pain. And CBC which was done showed hemoglobin of 9, WBC count of about 1,30,000, platelet of about 4,65,000, with about 2% blast in the blood. And bone marrow was suggestive of CML in chronic phase. Chromosomal analysis in the marrow showed translocation 922, and left femur tumor was biopsied, and biopsy showed blast proliferation with fibrosis, in which CD68 MPO was positive, and TDT, CD3, 79A, and 34 were negative. And on the tumor cells, again, they were positive for translocation 922. This was the sheets of glass, and then that is a CD68 staining on the right side and the IHC, and this is the lytic lesion which was there on the CT and MR. So patient was started on imatinib once a day, though the recommendation was dasatinib at that time, second line agent, but at that time they were very expensive. So patient was started on imatinib about 400 mg once a day, achieved cytogenetic response, no improvement in pain, and imaging showed increase in tumor. In fact, Marrow achieved a minor cytogenetic response too. And she was started on dasatinib 140 mg OD with IFRT of 30 grays. After 2 months, PET scan was normal. Patient achieved complete cytogenetic response, and RT-PCR for BCR-ABL ratio was 0.21%. So at this point of time, majority of the patients feel that we have become very well. So is there any need to do bone marrow transplant or allogeneic stem cell transplant? That too, this patient did not have a fully matched donor. But mind you, it is very, very important to know and to understand that each time patient comes back with blast crisis, it's very difficult to send them to remission. And then no patient maintains their CML milestones once they develop blast crisis without a transplant. So haplo transplant was done, and then she was continued on dasatinib maintenance, and she is in complete remission at 2.5 year follow-up at this point. So these are the 3 cases which will let us know how to manage this kind of extramedullary blast crisis. One is giving a TKI. Second is treating them with the acute leukemia-inspired regimens with the addition of a TKI, followed by, once they are in remission, to go ahead with an allogeneic bone marrow transplant. So without transplant, no outcome for no good outcome for this group of patients. With this small take-home message, I would like to conclude my talk. And then again, I would like to thank Dr. Mb Agarwal sir and then Lupin for giving me an opportunity to share what I know and then what we have seen with the patients. And I'm happy to take any questions if there are. Thank you.
Thank you, Dr. Nataraj. It's very well organized talk. Thank you once again, and excellent talk. We could not see any questions in the chat box. But I would like to, can I have a question? I think I would like to ask one question.
Yes, sir.
Yeah, that question is, I think once upon a time, we did not have the second generation TKIs. The patient, we used to start imatinib. If the patient develop any isolated CNS relapse, that means isolated meningitis. So how do you approach that case? Is different from this?
Sir, isolated CNS relapse, usually it happens with lymphoid blast crisis. Rarely it happens with myeloid blast crisis. It's not common. Yeah. So if there's a lymphoid blast crisis involving the CNS, patient should receive triple IT therapy. With I would always give ALL based. I would definitely do an MRD in the marrow with RT-PCR and then look at the flow and RT-PCR in the marrow. And majority of the times they usually have one or the other telltale sign that CML is still persisting in the marrow. And if there is no sign of marrow involvement, I would still give triple IT therapy followed by BFM based protocol for about a month, and then give them probably if they are quite give some sort of a prophylactic CRT, or give a TBI based conditioning regimen with some cranial boost, and then take them for sibling donor transplant or whatever the transplant that is feasible.
Thank you, sir. Any other comments from any experts, sir? Questions and comments? So if there are no questions and comments, and we'll move on to the next session. This is the most important session.
Dr. Soumya is not there. So we are going to close the session now.
Yeah, okay, sir. I'll hand over the mic to you, sir, now. Thank you very much for giving us this opportunity. It's a wonderful talk, sir, wonderful topics. I think rarely all of them, they have done very good job. We learned very many things. So thank you once again, sir, for giving us this opportunity.
Thank you. So on my behalf, I thank Lupin, especially Mr. Vishrat Mishra, Dr. Shikha Verma. This whole idea of developing a webinar on CML based on important publications and presentations during last year was from Lupin, and I am grateful to them because this was a great idea, And now at the end of the webinar, we can see how successful it was. Almost 300 audience, and our 5 great speakers have done a great job. We learned so much about the CML in this session. CML is now a curable disease. So any small mistake on the part of treating physician can doom the life of the person. Future is going to be still brighter. We're going to move from TFR rates of 40 to 60% to higher and higher as major breakthroughs come up. We are also now understanding how to fine-tune the treatment, and today's whole webinar was based on really fine-tuning the treatment of CML beyond what is routine. So once again, thankful to the chairperson, thankful to the speaker, and I hand over the platform to Dr. Shikha Verma on behalf of Lupin to do the vote of thanks.
Thank you so much, sir. On behalf of Lupin, I thank each one of you for your presence and for a very fruitful discussion. Thanks a lot and have a great day ahead. Thank you.
Thank you, Dr. Shikha, and thanks to everybody. Wonderful. Good night to everybody.
Good night.